You know, I thought this is one of the really exciting sessions in this meeting, and I was really pleased to be asked to chair that. It's about pushing the boundaries, and you will see that's really happening. In tricuspid therapy, it's particularly about the TricValve solution, and the session of 45 minutes is sponsored by Orbus Niche. At the moment, we've got Dr. Katharina Kiss and Angel Sanchez Recalde, and we're waiting Sondos Samagandi and Arif Al-Nooryani. He will be here a little bit later, hence we have changed the program, but we will be delivering the full content of the session, and we will give you a real good insight into a very exciting new treatment. Now, we used to open up a tricuspid session saying this is the forgotten valve. You remember those talks, right? Because we didn't have anything to do. Now we have plentiful of therapy options, and we're learning which are good for which patients. And there are patients out there. 1.6 million in the US have tricuspid valve-related issues requiring treatment. And TR, as you know from your patients, is frequently found in the operative management of left-sided heart valve disease. Recently, New England Journal of Medicine, a randomized trial by the surgeons showing that if they take care of the tricuspid whilst they take care of the mitral, the patients do better. So it helps. 35% of all the heart valve failure patients suffer from TR. And patients with severe TR, once they have it, the mean year to survival, the survival is 2.3. Non-severe TR can be managed with diuretics, but severe TR needs attention. In the European Union, 800,000 elderly patients are contraindicated for valve surgery due to high operative risk. So this is the basis, the foundation of having percutaneous options. And these are the learning objectives of our session: to learn about the TricValve system in the treatment of severe TR and right heart disease. Where can your patients benefit? To obtain insights from the experts with case scenarios, and to understand how the TricValve Bicavel system can help patients with severe TR. This was the planned program. Arif will come at the end now. We'll start with the clinical evidence. We start with some cases, and Angel Sanchez Recalde will give us a practical view of how this works with this valve. Angel.
Firstly, I'd like to thank the organizers for inviting me to participate in this very interesting meeting, and also to be here in a very beautiful city, in a very beautiful country. For me, it's the first time, and it's a great honor to be here. So I will talk about the patient selection and the procedural technique, and with two cases to show you the way of doing the treatment with this novel treatment of TR. This is my disclosures. So the TricValve is the only CAVI device with a CE mark approval very recently in May 2021. There is a very different design of the valves for the superior vena cava, for the inferior vena cava. They are made out of nitinol, and there is a valve inside these structures. There is a valve from pericardium, from bovine pericardium. And the design is quite different. It's quite different because one is designed for the superior vena cava, and the other one is for the inferior vena cava. 3 sizes for the superior vena cava, 4 sizes for the inferior vena cava. And the design, I will explain the parts of the valves. The upper part of the superior vena cava is the crown. It has a low radial force, only to get the stabilization of the valve and to get a good alignment with the superior vena cava. But it has a low radial force, no damage in the superior vena cava. The radial force and to fixate and to place the valve is in this part. This is the belly of the valve. And here there is a long skirt to avoid the backflow from the right atrium and the superior vena cava in this part. So this part has to seal the superior vena cava. And in this part, the lower part, there are the leaflets of the valve. The inferior vena cava design is quite different. In the upper part, has a high radial force to fixate the valve. In this part, there is a very short skirt, only 20 millimeters, to prevent the suprahepatic vein occlusion, because the suprahepatic veins are in this part of the valve. And the lower part is only with a low radial force, only to get to stabilize the valve against the wall of the inferior vena cava. There are two different designs for the inferior and the superior vena cava. I will show you the way of doing the implant of this device in a normal anatomy, the superior vena cava. This is the innominate vein, the confluence, the jugular. This is the superior vena cava and the right atrium. When the length is enough from the innominate vein to the right atrium, we can start to deploy the valve, the crown, in this part, in the confluence. And the most important thing is to implant the belly. The belly has the radial force to fixate the valve. The belly always have to be placed higher than the pulmonary vein, than the pulmonary artery. This catheter is where the pulmonary artery crosses the inferior vena cava. And always this part, the belly, has to be higher than the pulmonary artery. This is the key of the most important thing during the implantation. This is the echo view, the transesophageal echo view. This is the optimal position. This is the valve with a good motion of the leaflets. And this is in the entrance, in the roof of the right atrium. This is the optimal place for this valve. It's quite different for the inferior vena cava because the anatomy is different. The anatomy is, there are two parts, the suprahepatic veins and the cava atrial junction. We have to place this part of the valve with the skirt from the top of the superior vena cava until the cava atrial junction. The distance is variable. It depends on the anatomy. And the most important thing is to implant the valve only a few millimeters inside the right atrium. The optimal is 5 or less than is 5 or at maximum 10 millimeters, but it's better to get this result at the level of the right atrium. Almost 0 millimeters inside the right atrium. And this is the valve, the movement of the leaflets. This is the optimal position of the valve. So patient selection and the criteria, there are clinical, hemodynamic, and anatomical features. We have to select patients with symptoms in class 3 or 4, despite optimal medical treatment, with signs of heart right failure. We have to rule out patients with severe left and right dysfunction, in this case TAPS less than 13. And it's very important, the TricValve requires a tricuspid beat weight more than 15 millimeters of mercury during the right catheterization. It's very important, and it's important for the reason. This is the results of a patient with a low tricuspid beat weight. There is a lack of movement of the leaflets, no motion of the leaflets. It doesn't work because the patient doesn't have a good tricuspid weight, less than 15 millimeters of mercury. And also we have to rule out patients with severe pulmonary hypertension, mainly precapillary pulmonary hypertension. And anatomically, the features is that we have to select patients with a superior inferior vena cava suitable for TricValve according to the anatomy criteria by the cardiac CT. This is a good result. This is the pre-TricValve implantation. This is the pressure in the inferior vena cava, nearly 20, and in the end of the procedure, there is a significant decrease, nearly 10 millimeters of mercury. This is a very good result. Let me show the first case. Is an old lady, 80 years old woman with rheumatic valve disease, a pacemaker, mechanical mitral prosthesis, aortic valve prosthesis, a surgical ring, and now is in class 3 with signs of right heart failure, to admission last year, a very high level of BNP, renal dysfunction, normal hepatic markers, and in echo, the patient has a severe TR with RV dilatation and borderline right ventricular ejection fraction. In the cath lab, there was a moderate pulmonary hypertension with normal pulmonary resistance, and there is a very high big wave, nearly 24 and 25 respectively in the superior and inferior, and the patient needed high doses of diuretics. The predicted mortality using Euroscore is 8%, and with the new TRI score, this is a specific score for isolated tricuspid valve surgery, is very high, 65%. I will show you the echo. This is the transthoracic echo. It's a severe TR in a patient with a failed surgical ring annuloplasty with severe dilatation of right chambers. And the mechanism, we can obtain the mechanism using the transesophageal echo. There is the ventricular functional severe TR, secondary annulus dilatation, and also there is a posterior leaflet impingement with a pacemaker lead. In this 3D image, you can see the impingement of the posterior leaflet with the pacemaker. Then two mechanisms, and then so what to do with this patient? It's an old patient, very symptomatic, and high-risk patient. The only solution, in my opinion, is a transcutaneous therapy. But we have techniques to repair the valve. One of these is a percutaneous annuloplasty, like Cardiovan, but in this case, the patient had a surgical annulus, a surgical ring, and is contraindicated this technique for patients with a previous surgical ring. And from edge-to-edge repair is very difficult because there is a huge gap, 9 millimeters, and also the image is very poor because there is a shadowing from the lead, there is a shadowing for the mitral prosthesis, and it's very difficult to grasp and to obtain a good result using, for example, a tri-clip of a Pascal. So we decided to use, in this case, the TricValve solution. The first step is to do a CT scan to measure the length of the superior vena cava and the diameter, so at the level of the pulmonary artery, below and above the pulmonary artery. In this case is challenging because the superior vena cava is tapered and is very short. So the implantation should be as high as possible to avoid the migration and embolization of the valve into the right atrium. And the inferior vena cava also is challenging because the distance from the suprahepatic vein to the IVC right atrium junction of the entrance of the right atrium is very short, and besides that, the diameter distally is very small, 22 millimeters. So there is a risk of embolization into the right atrium. So there is a challenging case, but not impossible. This is a 3D reconstruction with the valves in the place, as high as possible in the superior vena cava, and as low as possible the inferior vena cava. The procedure is very simple: 3 axes, 2 left femoral vein, 1 to put a catheter as a mark in the right pulmonary artery, other pigtail in the confluence on the indominate to do injections, and the right femoral artery, there is the multiple purpose catheter in the subclavian, in this case, to exchange to a stiff wire, and in the end to implant the TricValve through the right femoral artery. In this case, the first injection show a very small jugular vein. For the reason you prefer to use the subclavian vein to do the stiff guide wire. This is the first injection from the innominate vein, and the problem is that we had to implant the valve, the belly of the valve, above the pulmonary artery, but the pulmonary artery is close to the innominate vein. So it's a challenging case because we have to implant this valve at this level, at the level of the confluence, but avoiding to occlude the innominate vein with the skirt of the valve. Start to unsheath the catheter and to deploy the valve. You can see the nose cone in this very severe angulation, the nose cone of the valve, and the innominate vein in this case is patent. We continue with the deployment. We are too close about to deploy totally the valve, and this is the final deployment. The 3 anchors are released. And this is challenging because we have to retrieve the nose cone in this part with a very angulated subclavian, and pushing and pull and push this rigid and stiff guide wire, we can retrieve the nose cone of the valve without any problem. The first step is to implant the inferior vena cava. This is the suprahepatic veins. This is the entrance of the right atrium. And then we have to implant the valve in this part as low as possible, but because the suprahepatic veins, the entrance is very huge, it's impossible to occlude the suprahepatic vein. But the most important thing is not to protrude too much inside the right atrium. This is the optimal position of the valve. We started to unsheath the valve. This is a self-expanding valve with control, with a pit tail to do injections in the suprahepatic veins. We are almost about to release the valve, and this is the final result. Always there is an ventricularization of the right atrium. There is an increase, an abrupt increase of the pressure in the right atrium, but there is a significant decrease in the inferior vena cava. This is the deco result. This is a minimal protrusion for about 5 or 10 millimeters inside the right atrium. This is the 3D image. And the patient in 1 year of follow-up is in class 1 or 2, no readmissions, no signs of right heart failure. Then BNP decreased a lot with a significant decrease, and the patient needed low doses of the diuretics, a big change in the quality of life. I will show you a second case. It's a different case. It's a young male case with an orthotopic heart transplantation, and the patient had a severe TR secondary to endomyocardial biopsy. And the mechanism was a small chordal rupture during the biopsy. So in this case, it's very difficult to repair the valve because there is a chordal rupture, and we decided in this case to implant a TricValve. The CT scan was suitable for the superior vena cava, also for the inferior vena cava, and we do the same procedure. With the procedure, to access the left femoral vein, to inject contrast in the superior vena cava, another catheter as a mark of where is the pulmonary artery, and this is the right femoral vein. Is the access to implant the TricValve system. A curiosity in this case, there is a dilatation of the superior vena cava, maybe secondary to the transplant, to the scar during the orthotopic transplant. And the way of put this valve is, in this case, is as high as possible because there is a risk of embolization in this part because there is a dilatation. There is a risk of embolization into right atrium. So the optimal position is in this piece very, very high, similar to the previous case. Then there is the valve. In this case, the nose cone is not in the subclavian. The nose cone is in the right jugular, and we start very high as possible. The belly of the valve always higher than the pulmonary artery to avoid the migration into the right atrium is the question. The deployment is nitinol. We have to do it very slowly. This is the value of the prosthesis. And this is the release in the lower part of the prosthesis, and always the belly is higher than the pulmonary artery. The release of the 3 hooks. We check the patency of the innominate vein. In this case, it's good. And finally, we implant the prosthesis in the inferior vena cava. We have 13 millimeters from the top of the suprahepatic veins to the right atrium. This is the optimal position. So we started to deploy the valve. This part there is a skirt. This is the white zone is when finished the skirt. This video shows the final release of the valve. This has to be done very slowly because it's nitinol. You have to wait the nitinol to go close to the inferior vena cava wall. This is the final result. There is also an ventricularization of the right atrium, an increase in the pressure of the right atrium, and a significant decrease in the inferior vena cava. This is the final result, but echocardiography, transophageal echocardiography, a good motion of the leaflets. And this is the final result of the angio. No leaks, no contrast in the superior vena cava or in the inferior vena cava. It's a very good result. And this is a spectacular four-dimensional CT. When you can see the leaflets, the position is very good. It's the optimal position. This is the valve in the superior vena cava. This is the motion of the leaflet. This is the innominate vein, it's not occluded. And also the prosthesis in the inferior vena cava, the movement of the leaflets. This patient also improved a lot, no readmissions, with less diuretics, and the follow-up was good. So the conclusion, the TricValve procedure is very simple and predictable, with less anatomical imaging requirements and also interventional skills than other transcatheter TR devices. Cavity valve is feasible, is a safe option to treat a broad range of patients with severe TR, mainly in patients with unfavorable anatomy for repair. Thank you very much for your attention.
There are a million questions, but we'll deal with the questions at the end. So now you've seen how it looks in a patient, and I think that should have whet your appetite. Dr. Nooryani now will go and have a deep dive into the technology, the concept, and how this valve really looks in detail. Arif.
Thank you, Andreas. Good evening, everyone. I think we are all at the end of the day and feel a little bit down. So apologize, first of all, being a bit late due to the traffic. You know, people here knows about Sharjah Dubai traffic. Well, first of all, I think Dr. Recalde had done almost 80% of the job. For us as interventionists, we come across a new area, which is the tricuspid valve, which is more complex than what we are. I thought I was done with the mitral valve and then come the tricuspid valve now. Now here we deal with more complex situation anatomically, and for us as interventional cardiologists, it is again something new for us to deal with. And I'm happy that there is a specialty for structural heart nowadays. But let's go here. We will talk about the concept. I mean, we know that we have, so for instance, a range of, in our lab, for instance, unfortunately, first of all, we don't have enough data here available about the prevalence in the Gulf so far. I hope we will get this very soon. But in our center, for instance, we have something like 3% of severe tricuspid regurg cases and more or less another 8 to 9% of moderate TR. So here we have the image of the TR that you see on daily basis in our echo lab. Significant tricuspid regurg is affecting really in the US. That's what I will be referring to as the data now available. 1.6 million people in the US. Out of them, in hospital, post-surgical mortality is around 9%. And multiple transcatheter devices being introduced and developed lately and brought to the market. None of them has demonstrated really superiority so far. So we come across four main concepts in this treatment. One is based on the annuloplasty, the other is based on the leaflet repair and coaptations, and the third is the heterotopic and orthotopic devices. For examples, as mentioned here, the Pascal, it was a triclip that it's been also coming more frequent into the interventional labs. And the transcatheter tricuspid valve replacement been also tried. Again, we have the band, the cardio band, that also showed some kind of success. And then again, finally, in the heterotopic, the two valves that been so far investigated, one is the TricValve and the other is the Cavi from Sapien. So, new treatment options for severe TR. We are talking today about this new technology that's been introduced in the past few years. And this is for the severely dilated tricuspid annulus mainly, poor leaflet coaptation, because that's the challenging, and differing this technology from others mainly, and prior pacemaker leads, which has around 11% of our patients that they have leads in this population or subgroup of patients. So bicaval valve implantation comes with a new concept away from the valve structure itself and might be a preferred option for those category of patients. Seeing and how Dr. Recalde just demonstrated is really looked very simple technically, but I tell you it is challenging. Developed for treatment for cava reflux mainly, present in cases of severe tricuspid regurg with high risk of open heart surgery, it is also designed to treat severe TR without touching the valve. The TricValve Transcatheter, or bicaval we call it, can bring about improvement to the NIHA functional class and the 6 minutes walk distance, plus the improvement quality of life as expected. TricValve is being seen now, demonstrated, so I'll go through this quickly. What it does, usually we are trying to avoid the backflow to the system and reducing the congestion, whether from upper part of the body or lower part mainly, which is more important, and promoting the RV remodeling, increasing the cardiac output as a sequence, and then symptoms certainly come improvement and reducing the long-term mortality. So the valve comes as a prepared and dry product. It is dehydrated and anti-calcified treatment being done for it and ready to use. It's a preload valve, so we don't need to work and prepare the valve. It comes really ready, and you can keep it in the normal room temperature. And it has preparation time less compared to the other technologies available. Handling of the valves is quite simple, and one team size is not as large as is used with other devices, and the risk of contamination is quite minimal. At the same time, high safety, procedure is quite safe and easy to use, and the durability of this device is really supposed to be long. Though we have the two different shapes here. One shape is different than the other. As you have seen already, the skirt length is different. The shape of the device itself is different according to anatomy of the neighborhood vessels. So we have in the IVC short skirt to avoid hepatic vein occlusions, and in the superior vena cava we have to have a long skirt to prevent the perivalvular leak. And both are made of bovine pericardium and leaflets already made out of PTFE skirt. This device itself is a self-expandable nitinol stent with a PTFE suture line and connectors. This is how it looks like. When we have started doing this case, we did the first case about 4 years ago. At that time, it's really totally different now. I congratulate the company because they have improved a lot about the delivery system and the device, because it used to be taking all the three-dimensional and do it kind of customized valves. Now they come in the kind of ready sizes, available sizes ready, so you don't need to wait. We had to wait 6 to 8 weeks that time to get the valve, but now you can have it in the lab and you get it in. So you have the 25 and 29 size for the superior vena cava and the 31 and 35 available for the inferior vena cava with a short skirt. Here it shows again how the deployment and the positioning, which was really clearly demonstrated. I'll go through this quick. And here it shows the pre-procedural and post-procedural reduction of the TR. And here again, the hemodynamic post again was demonstrated before. The A wave here came down dramatically from 37 to something around 15. Here's the difference between the annular remodeling and large coaptation gap. If we look at how it develops at non-vague, actually the different stage of TR, we know that this kind of stage, that moderate to severe and severe. Now the timing will be an issue to come up through afterwards. When do we send the patient for the TricValve? I think we will discuss this now in a moment, because that was the challenging for me personally in our lab, when to send the patient for this kind of procedure, especially if they were young people. That is the challenging situation. But for the compassionate therapy or old, inoperable patients, might be the decision easier, much easier. And here we can say that the conclusion, TricValve system, maybe it's a new and promising treatment strategy and option in our lab for our patients with CVTR, and is at high risk for open surgery. Since the bioprostheses do not touch the native valve, it opens up opportunity to treat patients with pacemaker implant and for patients with very dilated annulus or large coaptation gap. The clinical safety and efficacy of this device will give us some direction of the application into our clinical practice. Thank you very much for your attention.
Thanks, Arif. And before we go questions, we now we'll see the evidence, and Dr. Katarina Kiss will show us how much clinical data is already out there. Now, Dr. Kiss has been with this valve from the very beginning, from concept to now, and she knows everything about it, and she will tell us what the clinical evidence is as of today. Katarina.
Very much. Thank you for the very kind introduction. So I would like to lead you a little bit through the clinical evidence, and in the sake of time, I will try to make this as efficient as possible. I think we are all aware why we need to treat severe tricuspid regurgitation, because once tricuspid regurgitation has reached moderate or severe stage, mortality is unacceptably high. We have learned that we are treating patients with prior valve disease or pacemakers or other underlying diseases. I would just like to take you through the transcatheter to the clinical data, and here we have a special access program where by far more than 200 patients have been treated around the world in a so-called compassionate use, so patients with no other treatment option. We have the TRICUS-1, which was the first in human study with 9 patients now entering their 3-year follow-up, and we have the TRICUS-Euro study, which led to the CE mark, conducted in Austria and Spain. The device has also been granted the breakthrough device designation by the FDA, and the large clinical trial randomized is on its way under the guidance of the Cleveland Clinic. So I think this will be really exciting to see. Inclusion and exclusion criteria have been already introduced by Angel, so I will just go through that. I think it is important to understand that the patients that were treated in those clinical trials are by far more advanced than any other patients included in similar trial for TER technologies. So for the endpoints in both clinical trials, we have the assessment of symptoms, the NYHA stage, and the quality of life improvement, which I think is essential for this patient cohort. So there is the Kansas questionnaire as a primary endpoint, and then of course major adverse events, 6-minute walk test, echo criteria, and implantation success. It has been a non-randomized prospective single-arm multi-center trial, and on the behalf of the investigators and the Echo Core Lab by Pepe Zamorano, I would like to take you through some of the data. These are the baseline characteristics, and it's important to understand that more than half of the patients included in both clinical trials did have prior valve surgery. And it's also important that, for example, in the TRICUS-Euro trial, 94% of the patients were already in AFib. So not one single patient until now, up to my memory, was screened who was not on oral anticoagulation when being included in for the treatment. We also had 23% of pacemakers in the clinical trial, which I think is remarkable, as this is very often a contraindication for the treatment. All patients were in NYHA class 3 and 4. And if we look at the safety endpoints, it's, I think, very remarkable in this very sick patient cohort that there was 0% in-hospital mortality or stroke. We had one valve migration in the very early Tricus 1 study, but I think we learned a lot about the implantation, and so in the Tricus Euro study, there was one small migration which could be managed conservatively without any conversion to surgery. Patients can be treated in local anesthesia with TTE, which I think is essential in this patient cohort. And if we look at the NYHA class now, we can see a significant and quite impressive improvement in the patients over time. And this is combined from the Tricus 1 and the Tricus Euro trial. And we can see that at screening, 100% of the patients were in NYHA stage 3 and 4, whereas after 1 year, 88.6% of the patients had improved to NYHA stage 1 or 2. The same is true for the Kansas questionnaire as a marker for quality of life. Also here, significant improvement in both clinical trials. After an initial raise in BNP values, we could see a continuous drop, which is due to the right ventricular remodeling and recompensation. Improvement in 6-minute walk test, although we have to remember that all of these follow-ups were done during the COVID pandemic, which had a very strict stay-home order, especially in Austria and Spain for this elderly patient cohort. If we look at serious adverse events, and this is for the Tricus 1 trial, then we have 0 deaths in the first 12 months, which I think is remarkable. Those patients were really ill. There was no MI, no cardiac tamponade, and one patient rehospitalized for heart failure. Very similar in the Tricus Euro trial. Here, early mortality, 3 patients, but not device-related, so 1 trauma, 1 COVID patient, and then hospital rehospitalizations, and the major adverse event, or the most frequent, was major bleeding at access site. So if we put this in a diagram or in a perspective, then we can see that we have a high survival rate at 1 year. One point that needs to be further discussed, and these were data from the 3-month echo, where in the beginning we see an increase of the atrial size and the TAPSI going down a bit, but we see from our compassionate use patients that we have further analyzed that here we can expect ventricular remodeling later on. So there are 2 points that I just want to mention. I think it's open then for discussion. I think it's important to remember that patients were far more advanced in the disease than in comparable clinical trials. Despite this, we have very favorable results with significant improvement in NYHA stage and Kansas questionnaire, and maybe new data suggest that this might also convert in a survival benefit. And the echo data might lead us to implement a different diuretic regimen, which was recently discussed also by Jörg Hausleiter in the PCR tricuspid focus group, that we should probably maintain diuretics for 3 months in order to allow right ventricular remodeling. We might see that the significant improvement in Kansas questionnaire score might convert into survival benefit. So very dairy, and of course this is just early assumptions, but maybe we are able to change the course of that disease, which of course would be fantastic. Thank you very much for your attention.
That's an impressive set of data, particularly the safety. We have about 6 minutes for discussion. Before we allow questions, it just comes and goes. Sorry. What I'm saying is we'll have a discussion now, but before we do, I would like to know who in the audience is actively treating tricuspid regurgitation. Yeah, okay. Percutaneously, of course. Right, okay. So this is a new field for many of us. And let me just ask Dr. Samagandi, this is on the last slide, what do we do with the patients after you do a lot of TriClips. How do these patients improve? Is it simply the breathlessness, or do they change? And how fast do we expect?
So I have done many cases like using either the TriClip system or the Pascal ACE system. Some of the patients, they have improved dynamically within the first 1 week. And to the extent they stopped the diuretics, they thought they don't need it anymore. And then I have to recounsel them again.
That was on the slide, yeah.
Exactly. And I have up to 2 years follow-up. The complete right ventricle has remodeled to basically back to normal in terms of the size and the function. So they have better quality of life, better shortness of breath. And one of the dramatic things that we noticed, like they have multiple ER visits or heart failure admission, and that has subsequently stopped. And this is contribute to the improving in the clinical status of the patient because they don't feel the need to go to the emergency. And this is from the series up to 2 years follow-up.
Fantastic. To think what these patients did 5 years ago and still do in many parts. So, Angel, you've done the procedure. How long does it take?
This procedure is very quick. We can do it in less than 1 hour to implant the both.
Less than 1 hour, okay.
For this very innovative way of treating tricuspid regurgitation, do we take in consideration the pulmonary artery systolic pressure if it is very high, the RV if it is severely impaired, and how is the outcome for the lower limb edema? Because all what I see is not including lower limb edema and these things.
Oh, Katarina, probably.
Maybe I can answer this question. First, of course, the atrial pressure, I mean, we were excluding patients with a severely impaired right ventricular function because I think we have treated a lot of patients for a long time with optimal medical treatment. Some of them have burned out right heart failure, and I think there it's maybe too late to treat those patients. So we have in the clinical trials, we have also emphasize the patients should still have a remaining right ventricular function represented in a TAPSE of around 12 to 13, but also after annuloplasty, like a working right ventricle. And the question about the edema, I think is very important, and we will include this in the next studies because this is the first sign and the most impressive sign. So those patients immediately after, would say, starts after 48 hours and is a process of the first weeks, that really they get rid of their edema, they get rid of their ascites, they have more appetite, they can move more freely, and this is really impressive to see, and also is then represented in the quality of life.
And severe pulmonary hypertension?
We have excluded patients with severe pulmonary hypertension due to the fact that in a new technology you try first to understand how it works in a selected patient cohort. So in patients with severe pulmonary hypertension, the cutoff value here was 65. If you go above that, you might also then include patients with primary pulmonary hypertension. I think this is the next step. So we have to understand better which are the patients that we can really treat successfully.
Up to that, the rules for tricuspid goes the same, like the surgical. I mean, is not far away. So you have to evaluate the patient as a first and then the function of the right side. And there is a nice paper, like it goes with measuring, do a right heart cath in patients like those and see what is your peripheral vascular resistance to decide if you if you repair it will be benefit or not. So if you have PA pressure more than 20, like this is a number in the paper, and you have a peripheral vascular resistance less than 3, the patient will benefit from repairing it, i.e. between brackets, the surgical, but the same goes for it. And once you have something between 3 and 6, you take the TAPSE and you divide it on the mean PA pressure, and then if it's less than 0.36, then you might have an improvement and benefit. So the same goes. And for my patients, like I've been following, if the RV is so far gone, usually the clinical status of the patient is so far gone, because you're going to have now liver impairment, multi-organ dysfunction, and even if you corrected the underlying problem, the other organs will not pitch in and help with the patient, so you'll have worse outcome at the end. And then it will be attributed to the device rather than the patient. So try to stay away from them.
Final question.
Any worries about the long-term implication of raising the pressure in the right atrium? Long-term impact of that?
So that's probably again for Katarina. What happens? We don't have the natural left valve and atrium separation. It's all one big ventricular system and then the valve. That happens with the other system as well, Tricento, that is out there. So what do we expect?
I can only tell you that from the first patients are now entering their 3-year follow-up, so they are doing very fine. So obviously the right ventricle can cope with the situation in the right atrium. I mean, we are of course now getting all the echo studies and the CT studies, but from the clinical outcome, I think it shows, because what is one of the big advantages? If you put the two valves, you use the right atrium as a reservoir in the first moment. So the patient doesn't go into right heart failure. We do not need inotropic support. Very rarely that you need inotropic support for one of those patients. So obviously it is better tolerable for those patients, and they can cope with it quite long term.
Final question.
I have a very stupid question. I've been trying to stop myself from asking it, but I couldn't help myself. Sorry. I don't understand how the valves work. Do they stop?
Backflow.
So they stop backflow going into the vena cava. Okay, so why doesn't the pressure in the right atrium rise and be much higher than the pressure distal in both vena cava? Why is the pressure in the right atrium drop? We're causing obstruction at the level of the vena cava.
Function of the volume, I would assume.
There is a ventricularization. The systolic pressure in the right atrium increase, but the median is similar.
It increases.
Yeah.
Okay, because we saw a curve which showed that it does not increase, which didn't make sense. Okay, that's fine. Thank you.
There's plenty more questions, like, you know, why don't two Edwards don't work? Why can't you just implant into the cava inferior? All these questions you can ask them when they're outside, and we mingle. But we have to come to a close because I'm aware there is another session. So, in conclusion, we have a new intervention for patients with severe TR. That's the TricValve. In patients for high risk for surgery, we'll learn as we start implanting these. From the early experience, we see that patients have a tremendous clinical benefit. And of course, there will be confirmation of these results in trials to come, and we will see these results published and presented at our meetings. So with this, I thank the panelists, the speakers, and you, and I thank you for your attention.